So we're going to talk about low back pain. How many people here have had patients with a complaint of low back pain? All of you should raise your hand, because if you're not, you're on your cell phones, and I know it. So we all have patients with low back pain. What have you traditionally done for these patients, Dr. Kerr?
I give them all the pain that
You Lortab them up, even though you can't do Lortab anymore. You send them to the local heroin dealer?
Generally, I will search for red flag symptoms, take my history, any red flag findings on physical exam, like any weakness or non-genesis. Any absence of any of that or any significant continuous palpation. Try surgery, treatment, physical therapy, or have them perform exercise that it says if they can take more time on it says. Or if there are any other red flag signs of history of physical, I might progress the imaging. I usually won't get a plain film unless 10 minutes of palpation or something like that.
So what I'm getting from your answer is that you send them to physical therapy, you give them some stretches, and then as long as they're not having our warning flags, which we'll go over, you kind of watch. Do you do anything different? What kind of physical exam do you do?
Well, I'll do good strength, range of motion exam, passive and active.
So a neuro exam?
Yeah, good neuro exam. Make sure sensation is intact. I'll do straight leg raise. Actually, see how high I can get for back pain.
Okay.
And then also, just general neuromuscular.
Okay, so you do neuro exam and you do a straight legs test, right? And you push on the spinal cord and make sure it's not pain over the bone. Okay. Do you know that there's a ton more you can do for a physical exam? And that's what I'm here to teach you today. Some of this is something I'm just going to go over. I don't expect you all to do HVLA, but I do expect you to do a good physical exam. Why do I want a good physical exam if I can't do the techniques that I'm going to go over? What can you do, though? You can diagnose them right. Back pain is not just back pain. Is it coming from musculoskeletal? Is it neuro pain? Is it pelvic pain? Is it hip pain? Or is it my knees? So you should be able to do a thorough physical exam, because if you send somebody to physical therapy, on average it takes 6 months for our patients to get into physical therapy. 6 months. And by then, they're already coming back, and what do they want? They want their Lortab. And then we say, oh, I'm sorry, it doesn't come in 500 anymore. You must mean Norco. So it's a lot harder to make funny jokes with Norco than Lortab. Lortab has a better zing to it. But that's what they come back for, right? They want to come back for some pain relief. Most people who go to physical therapy, it depends on the quality of the physical therapist. How many patients have complained about their physical therapy sessions to you? Most, right? They come back and it's totally useless. Part of that is our problem and our fault, because we don't do a good job telling the physical therapist what we want done. How many of you say on your note, evaluate and treat? All right. They'll be like, oh, great, evaluate and treat low back pain. And you're sending this out to a variable quality of physical therapy, right? But if you can say that I have low back pain due to piriformis syndrome, psoas syndrome, SI joint etiology on the right, hip flexor, which is your psoas, you're probably going to do a lot better, because even if that physical therapist isn't that great, they're going to look that up. They're going to be like, ooh, what's that? Because when we get patients that we aren't familiar with something, if they have a diagnosis and we don't know what it is, we look it up, right? Then we might actually treat them correctly. So we do the same thing for physical therapy. So if we can pinpoint for them a little bit better what we're expecting out of them, it'll be a lot better for your patients. And you're going to have to tell your patients that physical therapy isn't a 6-week thing. You're going to have to be committed to doing these stretches and all of the things your physical therapist tells you for the rest of your life. Because most of the time, it's a conformational abnormality. And we don't really address that. You guys don't get that a lot in MD school. DOs get it. And it's funny because you hear about it all the time in veterinary medicine. Because if a horse has a conformation problem, or a dog, or I don't think we talk about cows that much. I'll have to ask my mom. But those are big deals because there are horses that compete. And if they have a conformation issue, then they are not going to perform. They're going to get injuries. Well, the same thing happens to us. We just have 2 less feet and don't have hooves. Some people, I think, might. But conformation is a big deal. And if you have a conformational problem, you're going to get an injury no matter what. Who's been at the VA with me and has seen he's a wounded warrior with an amputation on his left leg who was having severe back pain? Anybody here who was with me? So the kid comes in and he'd been blown off by all those other doctors, and I did an exam. The guy is an uber athlete even though he has a left leg amputation. It's below the knee, back pain. Nobody's done a physical exam on him besides saying, oh, you have back pain. We did a plain film. Shockingly, nothing was broken because he was like 24. And they kind of just blew it off and said, go to physical therapy or whatever. He couldn't get into physical therapy until he saw me, so he came in and I did a physical exam, and the guy had severe psoas tension. He had his orthotic was messed up. It was creating an artificial leg problem because his orthotic hadn't been readjusted since he got it, so it was either shorter or longer than it should have been, and it all correlated to his physical exam. So I got him back into orthotics, had him readjust his lower extremity orthotic because he was really scared because a part of his revenue and what he did was the Wounded Warrior Project because he went and played baseball. So it's like a semi-professional thing. And it was a very simple exam finding. I gave him some stretches to do at home. I sent him to physical therapy. I had his orthotic adjusted, and his back pain got better. I also have another guy comes in, and it is his right foot in, I think it was Desert Storm, had a massive ankle fracture, so it's fused, but it's fused in plantar flexion. So he's basically walking with one high heel every day. So if a girl can imagine having one high heel on every day, your leg, your back, your knee, everything's going to hurt because it's a complete conformation problem. So he comes in, and we're trying to get him into an ankle specialist so we can get some range of motion in his ankle. He's had chronic knee pain. I gave him some exercises with that. That got better. He came back in and he couldn't sit still, and he's a driver, which makes things worse because he sits all day. And he couldn't sit still because he had such bad back pain, and he had to shove his hand underneath his butt. Anybody have any low back pain here? Do you ever drive and you have your hand underneath your butt because it makes the pain better? So he was doing that, so I did a physical exam on him, sent him to physical therapy with specific instructions about what I wanted them to focus on, and I gave him his stretches to do at home, and I gave him some Flexeril. I'm not opposed to that. And he can't have pain medication anyway because he drives. Comes back, and he's doing much better. The ankle's still going to keep causing problems, but I said you have to be committed to doing all of these every single day for the rest of your life, otherwise you're going to have that back pain. And it's going to be very easy to get your back pain because of your ankle. I can't fix the conformation problem, but I can at least help him with his back pain relief. So he came in, he was able to sit in a chair without shoving his hand under his butt, and he wasn't, I would touch him and he'd jump. So that was 2 weeks after he was able to sit still and be able to function and drive better. So low back pain is a problem, and you guys aren't given the tools to do a good diagnostic exam. So in the neuro exam, just like Alan said, your L3, L4 disc, it's the L4 level. You have tibialis anterior, your plantar reflex is affected, decreased sensation of the medial foot and leg. L4, L5, it's the L5 level, you get foot drop, so you can't stand on the heels. Tibialis anterior is affected and possibly flaccid. Variable deep tendon reflex findings may or may not have mild involvement of the patellar or Achilles. Decreased sensation to the dorsum of the foot and the lateral leg. Straight leg test is often positive. L5, S1, the S1 level, unable to stand on one leg and stand on toes. Gastroc and soleus are weak and sometimes flaccid. Achilles is weak or absent. You have decreased sensation on the lateral side of the leg and foot. Straight leg is positive on one side and often causes sciatic pain on the contralateral side. Claudiquina is a surgical emergency. Call neurosurgery. This is a time-sensitive issue. If you can, it needs to be done in less than 6 hours. Because if you talk to any neurosurgeon when it's over 6 hours, they still will likely do surgery, but it's no longer emergent, and they have less ability to restore function. So the 6 hours is still that golden number for vascular and neuro. Okay. So motor weakness, sensory loss, or pain in one or more, commonly both legs, saddle anesthesia, bladder dysfunction, bowel incontinence, sensory abnormalities in the bladder or rectum, sexual dysfunction, and loss of reflexes. So the sacroiliac joint pathology, you can do a seated flexion test, and I'm going to show pictures for these so they'll actually be able to have meaning for you. On the side that's affected, you'll have somebody, you put them in the sulcus in the back, the PSIS, and you have them just lean forward, and they typically, if you don't have any etiology, should move smoothly. But if you've got something where one is restricted, that's usually where you're going to look for your etiology. So the Faber sign, also known as the Patrick sign, it's pain in the SI joint. So, do I have a clicker? I do. So this is an anterior view, obviously. Your SI joint. You're going to look at, back here you have your iliolumbar ligament, anterior longitudinal ligament, and the anterior sacroiliac ligament. So when you have pain back in here, and there's a better picture on the next slide, it helps tell, are you having musculoskeletal pain in the lumbar region? Are you having pain in your lumbar spine? Or are you having pain in the SI joint? All that makes a difference. Pain in the anterior femur, when you're doing that, is more indicative of a hip pathology, so not the SI joint. So you move from here to here. Iliac compression and distraction test. Pain with compression and relief with distraction. Because when you're doing the compression, it's putting pressure in this region, because you're going to use the anterior superior iliac spine with somebody laying on their back, and you're going to do some compression and push down in there. If there's irritation, obviously, or strain, that's going to cause pain. If you do the distraction, it should relieve your pain. All right, here you go. This is a posterior view. I'm just sitting up here hoping I'm not doing this backwards. Obviously, this is so posterior view, just looking at your pelvis and the sacrum. Here's your SI joint. You have all these different axes that we use to help with diagnosing. Obviously, I don't expect you to do that. They spend several semesters teaching us this in DO school. What I want you to do is start thinking about, where's my back pain coming from, instead of just diagnose them with low back pain, okay? Because there's a different treatment for here, 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 and here, okay? And then sometimes you get pain up here. And then we just talk about axes both from you're looking out on this side and then a cross section through. We have different ways that the sacrum should be moving. Again, this is just a good picture of how everything sits into your spine and your skeletal system. It's good to remember this stuff because we often forget once we're out of pathology class. Your ilium, here's the lumbar spine coming in, and then your sacrum, again your SI. Just some more pictures on what we're going to talk about. I'm not going to go very detailed into the sacrum just because it is very confusing. But I just want you to know that these are all different modes of motion, and when they have some restriction there or muscle tension or ligament inflammation, you're going to have pain at different points on this, okay? This is just a test. It's called the spring test. It helps us with talking about torsions. This is a very confusing depiction of how we diagnose the sacrum. We can have anywhere from a backward torsion, forward torsion, an anterior sacrum, a posterior sacrum, a unilateral sacrum, all these different things. But really what this is here for you guys is to see where you have the different points. So here's your tissue texture abnormality. It's usually, anybody feel somebody when you're feeling their back and it feels ropey? Or it has something like a lump there and they're a little tender? Well, that's what we consider that. And it just tells you, these are all different points. So you can have, if you're looking at somebody, this is them facing away from you and you're looking at their back. This is where their bottom is. It's called the rectum. It's underneath the sacrum. And this is where your insertions are coming on each side. So you're going to palpate and just tell me where the tenderness is. That's all I'm really looking for you guys to do. So when you do order physical therapy, it makes it useful. And if you had physical therapy, they actually have training in this. They do a lot of myofascial stuff now and things that usually not the HBLA because that's not something they're going to be trained in. But they'll do myofascial releases. They're going to do stretching. They're going to do strengthening. So telling them where the point of pain is going to be very useful. So we have the backward bending test. I'm going to go through what these are, and then I'm going to show you pictures of them. And what that is it lets us talk about, because we do talk about this often, somebody who has spondylolisthesis or spondylosis, DJD. It kind of helps us pinpoint where that might be, what lumbar area. We talked about the straight leg test. When you go from 30 to 70 degrees, it can either mean a lumbar nerve root irritation, so coming back up here, or it can mean a sciatic nerve irritation from a tight piriformis. And right here is the piriformis muscle, and you see how the sciatic nerve comes through here? There is some anatomical variation where sometimes that sciatic nerve comes through the middle of the piriformis muscle. Who runs here? Something more than running away from cops or something. Well, seek. Do you ever get low back pain from after you've worked out a lot? The other extreme would be somebody who's sitting many hours a day. Does anybody get butt pain or low back pain from that? Okay. Yes. So the reason you're getting that is because your psoas muscle right here, you have an insertion coming off of these lumbars, and they insert down into here. That gets tight and it pulls you forward because it's your hip flexor. That's the biggest. This is the tenderloin on a beef cow. So just think about that next time you eat that you're eating the psoas muscle. Again, major interesting points I'm here to give you. So when that gets tight, it pulls you forward. You've all seen the muscles. I can't talk. The musculature in your back. They're all small, thin muscles, but tons of them. So they get strained easy. When your hip flexors get tighter with running and sitting too long. So give me some common patients that we see who come in with low back pain, who sit a lot. Right, truck drivers. They will come in all the time because then they get out of they're usually not the most svelte people in the world. I took care of somebody at Kindred the other night. She was 400 pounds and she had a semi tattooed on her arm because I think she used to be a truck driver. So they're not usually healthy. Call me crazy. They get out of their truck. They've been sitting there because if they do across the road, they'll sit on their truck for days. They get out and then they help move around whatever their load is, or they get out of the truck, they torque their back, and it's because they're sitting way too long and not stretching. So everything in their back strain. So most of those people don't actually have nerve root irritation at the beginning. It's that they keep irritating their back and they can get a bulging disc. So if you can intervene and teach them stretches, you might be able to prevent some chronic low back pain. Your Thomas test, this one helps us tell if you have a tight rectus femoris or a tight iliopsoas. Again, we're going to go back and show you what that is. And here's your rectus femoris, okay? Because when we all work out and learn stretches, we learn stretches for this. But we never learn the stretches for that, okay? So that's where, and this pathology is way more common than the rectus femoris being tight. You have your Trendelenburg test. It tells us if you have a weak gluteus medius. The reason that's a problem is because then your pelvic bowl is shifted, your iliac crests are off center because you have a weakened muscle in your butt, because your pelvic stability is all about those muscles, okay? Here's this picture of how you start with a seated flexion test. The person just leans over. Depending on these, both should raise and fall at the same time. There's controversy in how accurate, obviously, this is, but it's not the only thing you do. You do many other things and try to weed it down. So you take a bunch of slightly accurate tests and put them together, you might get an okay diagnosis, okay? That's Anna's math for you. I will teach statistics next week if you'd like a little bit more detail. So you just have them lean over. The finger may go up higher than the other. You have a dysfunction showing that either restriction in one or the other areas. Here's that Faber test. Remember, you're looking at either an SI joint pathology. So if you're having pain, oops, that's not where I wanted. There we go. Sacroiliac pain. So when you're doing that, you're pushing down to their cross leg. You're pushing down on that knee, and if it reproduces pain in that back area in the sacroiliac, you have a better idea. If you then start having pain in the femur, on the side that you're pushing down, then you can have a better idea. It might be the hip, okay? Iliac compression and distraction. So this is actually, you're taking your hands and pushing out. So in the back, that's pushing together. And if you have irritation there, and then when you distract that, because then you're moving the crest up and relieving the pressure in the back, then you have a pretty good idea that it's sacroiliac. Here's the backward bending test, spondylolisthesis, spondylitis, DJD. So you have them lean back into you, and then you can kind of pinpoint more where that pain is being more reproduced. Straight leg test, I think we've all done that. Here's a Thomas test, and what this is really outlining is when you have a tight rectus femoris, you can't bring your knee all the way back. This you should be able to drop it down. You see how this is more of a 90? And here she can't bend it back more because that's too tight. It should physiologically make sense. It's not the world's best picture. This one, what they're trying to show you is that you can't drop your knee down anymore. You should be able to have around here to here of a knee drop, and it's because your psoas muscle's too tight. This is about your gluteus medius. So this is negative. You lift this leg up and it stays even. If you lift this leg up and you drop, this muscle here is your problem, okay? Now, psoas muscle energy is your first thing. I actually have done this in clinic. I think somebody's seen me do it. It's something to give back pain relief, usually that day. Not often can you just do this and then their back feels better right away. The whole thing that this person's doing is they're laying on their belly. Alan, you want to come up here for a second? This is something that I want you guys to do. I want you to take your shirt off.
Really?
No. All right, I want you to lay on your belly. He was considering it. Did everybody see that?
There we go.
All right. So.
I'm real tight right around here. Oh, that's nice.
So what you're doing is that this patient's laying on her stomach, it's her left psoas that's tight. And I have a feeling that you probably have a tight psoas because you have pain down here.
Yeah.
So what you're doing is on this side that you think it is, and I'll show you the different. Who does yoga here? Anybody?
And never went again.
You've done one more time of yoga than me.
Just one time.
I'm going to say probably not Steve Richards.
Don't let you drink.
Sarah. Are you flexible? Do you stretch?
Yeah.
Would you be totally embarrassed if I showed them the difference between his psoas and your psoas?
Oh, actually, quite flexible.
I don't want to know about your weekend. All right, you don't do any work. Take your hand, and I want you to do it above the knee. Don't just lift your leg up below the knee. It'll hurt your knee. And then you put your hand on the back of his sacrum and kind of stabilize him. And then you lift up, and you see how far this woman's leg is? She's actually an OM fellow. She's not going to have psoas dysfunction. But he can get his knee underneath there. Alan's, I can get to here. So what you do, huh?
We can't see through if you go on the other
What do you
side.
mean?
On the other side.
Scoot over this side. Okay, so just pretend you would actually do it on the same side you're on, because otherwise it'll hurt your back. Put your hand here, and you can see that he gets pretty.
Okay.
I'm gonna have nightmares. Okay, so bring him up to here. So you hold this down because you want his pelvis to be straight. Push down in my hand, like
Push down?
Yep, a little bit less.
Okay.
You have him do that for 5 seconds. Okay, relax. And then you bring it back up again, push down. Relax. Wait a few seconds. And then do a nice stretch. So then you can do it on the same. Most people have a little bit on each side. So this side's a little bit worse, but not bad. So push down. Relax. Push down. Relax. And stretch. Okay? So at the end,
You're just basically doing like that stretching all day.
so I'm having him activate into, so he pushes down while I don't let him go anymore. It's called muscle energy. So then when he does that, it's supposed to activate the tight muscles. So then when I go and let him relax, I can bring his leg up a lot more. Okay? He's not actually too bad. I'm trying to predict Lassie. He's a little cricket player. Come here. So that's muscle energy. I want to show you somebody with tight psoas because when you see it in your patient, you're all yes. This is and then you can give them home stretches. We don't have great pictures. You know, maybe Dr. Parker, but just have them Google. All right. Let's just see. Relax your nose. No clenching your butt. All right. So with that, I can get to about here and lost it. Push down. Relax. Push down. Relax. The thing that people do is they try to lift it up for you when they're using their butt muscle. But this side's a little bit better. Do you have pain on this side? So that's somebody who has a little bit tighter of a muscle. That's going to be your most common cause and something super easy to fix with your patient. This is the other one. Remember the piriformis muscle I showed you? The one in your butt? Runners get that a lot. It's usually right about here, and sometimes you get sciatic pain with that. This stretch actually will give you instantaneous relief from your pain. Yeah, so if you've got sciatic pain, A lot of times it's just piriformis. It's not actually a bulging disc or a nerve root irritation. It's the piriformis. Because some people actually, it gets so tight that it irritates the piriform or the sciatic, or the sciatic goes through a portion of it. So when it's tight, it'll give you that pain. Now I actually had this problem back when I was in my 20s, when I was a nurse. I worked in Wisconsin, and there's a lot of people who aren't little because we eat a lot of beer and cheese. So we had quite a few bariatric patients. So we did a lot of lifting and turning. If you have a patient that's all dead weight and they're 300 pounds, this is before we had all the little technology we have to lift patients with lifts. You'd have to reach over the bed, and remember you got 300 pounds underneath you, take that patient, grab their leg, and pull them over. And so I had really bad back pain, and I drove around with my hand under my butt, and it went down the back of my leg. I started doing these stretches, and I had this technique done, and my back pain went away. I continued to do those stretches, and I have not had any since. So it's a uncomfortable physical exam, and I'm not going to make anybody come up here for me to show you how to do it because it's really not comfortable because I'm pushing on your butt in front of a bunch of people. But when you're looking at this lady, here's the back. Here's probably where her PSIs are. Is, both, whatever. Right in this area is where your piriformis is. And you can actually feel when somebody has a really tight piriformis, it feels like a big rope, and you touch it and they'll jump. It's very tender. Anybody remember Scott Kelly? Okay. I didn't touch his butt, but he had really bad piriformis syndrome. He is somebody who does the Ironman every year, and then he does marathons throughout the year. Very, very, very heavy runner. And if he didn't do his stretches, he would get this. And it's one of the few things that you get that instantaneous relief from your pain. Okay, here's just the gluteus medius strengthening. We talked about how you can do an exam on that, the Trendelenburg. And it's literally you just doing this, and you do it 10 times. You do 3 sets of them on each side. And you can put a weight on your ankle to make it more difficult, but you're just tapping and moving. And that motion is just doing it. It's hard to strengthen your gluteus medius unless you have Brazilian butt, which costs $80, and you often just leave it in the package. So this is a lot easier and cheaper to do. Here's a gluteus maximus strengthening. This one, you're going to start, all you're doing is just laying down on your back, your butt sitting on the table, and then this is also good for your core. It's just a good exercise to do for general strengthening. And then you take your butt and you lift your pelvis up. Trying not to use your thigh muscles to lift you. You're trying to use these muscles to lift up, so you get some strengthening that way. It does help with people who have knee pain with running, ironically. So this was a part of a strengthening exercise that some runners were given who had some knee pain. Okay, again, I talked about muscle energy. The patient's active force is engaged into the physician's counter force, meaning I'm not going to let you get past where I said. It decreases joint restriction and muscle hypertonicity. HBLA, that's the thing that everybody usually thinks of when they think about chiropractors and DO. You don't actually have to do a lot of that, but you're doing a quick motion. So you're not jumping off a table onto somebody's back. You're taking a motion that's probably only this much, but you're doing it in the right manner and correcting. It's a quick relief of pain. It's like when you crack your own neck. It's your own little mini HBLA. Counter strain and facilitated positional release. If you know how to do this, works really well. I did this for one of my friends. She has psoriatic RA, and she had chronic pain in her elbow, and she couldn't really use her elbow to get out of a chair. So one day we were drinking, and she told me about the problem, and she said, you know, what do we do? And we were just sitting around having a couple beers talking. And I said, well, let me look at it. And I played around with it. and I found the point where she was having most of her pain, and I did counter strain on it, and she had complete pain relief. And that day, and she did not drink so much that she couldn't feel the pain. So that's not the cause. But I'm just saying, if you do it right and it's the right type of problem, people get pain relief right away. Facilitated positional release is the same thing as counter strain. You move the person into a position where they're not having pain at that point anymore, and you just do some compression, or you just turn it a little bit in there, and that helps release a lot easier. These are hard to understand unless you've actually seen it work. Here's some more stretches. Again, what you're doing is you're taking the affected side, standing up by the chair or table, whatever works for your height. Mine would be a chair or a stool. And you put the back of your foot on there, and then you just drop your knee, and you should feel that stretch in there. Okay? So you just kind of come down into it, hold it for 15 to 30 seconds. A lot of people don't stretch long enough in their hold, a minimum of 15 to 30 seconds in each hold. Counter strain is that thing where I told you this person's having pain in this area. There are 3 common tender points there. So he's got his finger on where the point is. He moves the patient until when he's pushing on there, she doesn't feel the pain. And what that really is doing is you take a muscle that's strained and you kind of reduce the tension on it so it doesn't hurt anymore, and you hold it there until it relaxes. You have some posterior ones on your lumbar spine. This is an extended dysfunction. Basically, that's saying that your spinal cord sits neutrally like this, and then if it's extended, it's tilted back. If it's flexed, it's tilted forward, and then you get pain around those areas. So this is one of the facilitated positional release. The patient's laying on her tummy. She has a pillow here and a pillow under here. Before he makes any movements, he finds that point, and then he keeps moving the leg out and towards that point until she doesn't have any pain. And then with the pillow there, it helps get the muscle to relax and release. PTs do this a lot. They do the counter strain in the FPR a lot. So it's not just voodoo medicine. Many, many different people use it and it works. This is for the flex dysfunction. So we're using the knee and we're turning the foot back and forth until we don't have pain at that point. This is when you have an anterior nominate, you're doing some muscle energy. What this patient's doing is that she's moving her knee back, and then the doctor's asking her to put force into his hand, and he's not going to let her move. And then once she relaxes, he moves the knee closer to her chest. She does it again. And then the same thing I did with that psoas one. Posterior nominate, he's taking that knee and lifting it up, and then asking her to push down into his hand, and he's going to stabilize her here. Then same thing that you're doing for the psoas muscle, but for a different portion, for a different reason. This is HVLA. So I'm not going to teach you how to do that, but I want to show you what you're doing is you take your diagnosis from where the pain is on the sacrum, all the different tests you did to say that they're positive, and then you diagnose an anterior sacrum. So we have different techniques for this. Has anybody had this done to them? Allie? Okay. Have you had any back pain? Yeah. Okay. What about you, Kristen?
Yeah, I've had it.
Okay. So I get this a lot because of my piriformis. So this feels awesome when you get it to go because you get the pain relief right away. But again, the issue with HVLA is that that'll help, but a good doctor will tell you how to do the stretches and strengthening so you don't get that dysfunction again. Mine is my piriformis because I don't stretch it when I'm supposed to if I go running, which has been very rare lately. But this is something that you can correct the dysfunction right away. It's not stretching where it takes a couple days or strengthening which takes longer. But you have to remember that you have to give, the doctor needs to know what the treatment is after that. And why am I telling you that? Because you probably aren't going to do this, right? How many patients do you have that go to a chiropractor? Or ask you about a chiropractor or something else they can do for their back pain? Anybody had a patient ask them that? So a lot will, probably not here, because our patients may not have the money because it's all out of pocket. But when you're saying yes or no to it, what you want to have them do is go somewhere and talk to them about their treatment plan. If they go somewhere and the person tells them, oh, I'll crack you, and they have them come back every week for 6 months, that's $100 a pop. That's really expensive, and he has not given them a plan. So what I tell my patients, because I don't do this, I'm not licensed to do this, I say, okay, that is a possibility, but here's how I want you to determine if you're going to a good doctor or not, or a good chiropractor, because there are DOs that you can send them to. They need to have a plan. It's okay for them to give you a back crack and then make you feel better, but you should be getting exercises to make sure that doesn't happen again, and they should have an end point in their treatment. If they're going to see you every month or every week for 6 years, they're making money off of you, okay? That's not a treatment plan. So that's how you help your patients use alternative therapy, because there are people out there that are just making money off patients. So you want to give them a little direction on how to figure out who's good or not. This is just a picture. So you're taking the hand, this area, and moving it back that way, and then pushing down at the hip at the same time, and that helps treat your posterior sacrum. You should hear a click. A forward torsion, this is a muscle energy, so it's not as dramatic. That'll take probably till the next day to feel relief. But the patient's legs are draped off. She's asked to lift her legs up towards the ceiling, and you're not letting her move past where she is. And then once you hold it she pushes against your hand for 5 seconds, you wait, and then you stretch her out. And that helps fix torsions in your back. And then same thing, you keep one leg on, this leg's draped off, she's going to lift up towards the ceiling, and you're going to stabilize her here while she's doing that. Again, you're stretching out the muscle that helps or causes the torsion in the first place. And this is question. Anybody have any question? I know it's not hugely easy to sit here and have me talk to you about it. The whole point of this lecture for you guys is, one, to show you what's out there, and two, think about how you do a physical exam. Because you should be able to tell the physical therapist more than the patient has low back pain. And just kind of with these simple tools and doing an exam, saying, oh, he's got a tight psoas. You don't even have to do the muscle energy that I did on Alan. You can just have them lay on their tummy and then lift up and see how tight that is. Somebody who truly has that, you can't get them off the table more than that much, okay? You should be able to have a range of motion about that much. They should be able to lift their leg up, at least that. But if you can't get them off that table, then that's most of their problem. And you're going to see a lot with truck drivers. Just play a game for me and do this part of your physical exam on the next time you see a truck driver, and you're going to be pretty amazed. The other thing is knowing which stretches to send them home with. So if you're feeling like it's the rectus femoris, show them the right stretch. If you think it's the psoas muscle, show them the right stretch. And a lot of times on the internet they'll have good demonstration on how to do the stretch at home. So if they are not sure, especially in geriatrics, they have geriatric variation of those stretches, so you can go back to the computer, Google it, print them out the pictures, and send them out with some better treatment than Flextrol and Lortab. Okay? Any questions?